You're live on a brand new episode of Ladyz Digest, where issues in the world of women are discussed. And Ladyz Digest is proudly brought to you by AAU TV, the voice of higher education in Africa. Birth is a miraculous and joyful thing, and natural birth may be the way our bodies intended to bring out our babies. But there are situations where this just isn't the case, and then it is inevitable to talk about cesarean section as a means or a form of childbirth, either to save the mother, the baby, or both. And the month of April happens to be the Cesarean Awareness Month. And so my guest and I are going to be enlightening you all on the issues concerning cesarean birth. Remember, you can join the conversation. You can drop your comments and your questions on our comment section on Facebook and YouTube at the Association of African Universities and at Ladyz Digest on Instagram. I'm Joan. Do stay tuned. Welcome back to Ladyz Digest, and as I said earlier on, you can join the conversation on at Ladyz Digest on our Instagram handle and Facebook and YouTube at the Association of African Universities. And I have in my midst our regular guest, Dr. Owusu-Ansah, to help us digest the issue. Welcome, Doc.
Thank you.
How has your week been?
Been good.
Oh, okay.
Tiring but good.
Tiring but good, yeah. As a doctor, I think that is always expected. Yeah, so today, this is April is the month of cesarean section, and I just said we should talk about it at least to help our cherished viewers get one or two things. So I'll start with the very basic question as usual. What is cesarean delivery?
Okay, so cesarean delivery refers to, it's a major gynecological obstetric surgery that is aimed at delivering your baby via the abdomen.
Okay.
So naturally there's one route, the vaginal delivery, which is the natural. But in circumstances where that is not possible, we deliver the baby via the abdomen, and that's a C-section. Okay.
All right. So where, as you said, in cases where it's not possible, when does that become the only option? Like, it's either cesarean or nothing else. In what cases or circumstances does that become?
Well, there are several scenarios. It could be under emergency circumstances.
Okay.
Where acute sudden turn of events would necessitate that. Okay. Or we do a planned one, we call an elective delivery, where there are certain parameters that make it clear that you cannot deliver this baby vaginally when the time comes. So we do an elective delivery. So for example, if you do have, let's say, maybe a small pelvis, usually in labor, you are looking at three parameters. The contractions, which we call the powers. The passage, which is the pelvis, and the diameters or dimensions it presents, which in every woman, every adult woman, is fixed. Once you are grown beyond 20, it's fixed. So you can add on to that one. Then the passenger, the size of the baby coming. Those three things determine the course of labor. Okay, good. So sometimes if the passage is small, then you know that, possibly the baby coming cannot pass through this. So you have a small passage and a big baby. During the course of the antenatal care, you can tell that, this baby may not go through this passage. So down before the time, you can confidently say that we have to deliver by abdominal route, which is C-section. Then maybe you have a scenario where sudden onset of heavy bleeding at the time when baby is almost due. You probably don't know the cause, or maybe the placenta has separated prematurely. Then you have to rush and deliver. So it's an emergency situation. If you're waiting for natural onset, outcomes might not be good. So under emergency scenario, you do a C-section. So those are the two main broad scenarios under which a C-section can occur.
I guess, because I think maybe delayed labor, but I think delayed labor can be as a result of maybe the pelvis not being open enough or something. I know delayed labor can equally...
Yes, so delayed labor has various causes. But I think what you are referring to is what we call a CPD, so we call it a cephalopelvic disproportion, where the head of the baby or the baby's head and the diameters presenting, it's not adequate enough to fit the size of the pelvis. So there's no way that baby can come out through this passage.
And so that wasn't noticed maybe during the antenatal.
Labor is dynamic, so sometimes there are certain parameters you cannot tell. So labor starts. Then you realize that things are changing. So there are multiple factors.
I see. So we know that there's risk in even childbirth in general when going to deliver. I know they always say childbirth it's between life and death. So even the natural way, there are risks associated. But we want to talk about the risk associated with cesarean section. What are some of the risks that are dynamic to them alone?
Well, if you are, so I presume you are referring to the person undergoing a C-section.
Yes.
Good. So potential risk of complications could be maybe intraoperatively, when you're having maybe bleeding that's hard to control, or you're having maybe inadvertent or accidental damage or dissection of other surrounding structures like the bladder, the ovaries, any other surrounding structure, or the intestines that are close to the womb as well. You may have the need to have to remove the whole womb as well, as because of the bleeding, which is difficult to control. Post-operatively, yes, you can have immediate bleeding again into the abdomen if surgical technique wasn't the best, or maybe one of your sutures came off or something. And then maybe in the longer term, post-operatively, there's a risk of embolism, which is a DVT. There's a risk of wound infection, which can make even the wound gape or open up again. So those are some of the risks involved.
So still talking about the risk, I know in the olden days, when you mention CS, it's more like a death sentence. When you hear that a woman has underwent cesarean section to give birth, then I used to think that the ratio was quite low of successful ratio. But now we see that it has improved, and even some couples decide to just opt for CS as for their own. They don't want to stress themselves to go through the vagina. So I want to know if what improvement has taken place that it seems the success rate is higher now, or you wouldn't support me on that?
I think the success rate has always been okay. I mean, a lot of babies who are now in their 40s and 50s are probably born by C-section. So the success rate has always been there. I think generally, what I would say is maybe surgery has become safer in our environment. So there used to be, I think when we were much young, used to be the notion of if you're having surgery and the lights go off, you're dead.
Yes, that's true.
Which was like a myth. But then it was based on the fact that at the time, most of the anesthesia was general, so you're put to sleep. Your breathing might be managed by machines, the anesthetic machines and stuff like that. The operating lighting system was also electricity operated. A lot of the things, sterilization, but today in modern surgery, aside the skill improvement where you have more anesthesiologists who are handling anesthesia, there's also spinal regional anesthesia where we don't put you to sleep again, particularly for C-section. Good. The light systems have battery backups. Anesthesia machines have battery backups.
So even if the light goes off.
So technology has evolved to make surgery safer. So I think probably it came from that notion that once lights go off, you are dead. You are dead.
Because everything goes off and
exactly. So I think that anesthesia improvements and the technological improvements have made it safer. So it's not as scary as, and probably the replication of the proliferation of the surgical skill as well.
The
where
skill.
more specialists have come in now More people are now trained to do it. So I think a lot of
science is evolving,
a lot of factors have contributed to making it safer. And now people's confidence in C-section has gone up compared to before. Because
I know of women who just say 3 of their, maybe they gave birth to 2 or 3 children and all were CS. They just opted
some people plan for. I mean, that we call that for social indications, but that's medically we don't tend to encourage that.
Oh, okay, I see.
Usually there should be a medical reason, because touch wood, should complications happen, you can't defend it.
I see.
Saying that mother preferred this, it's not a very strong reason.
I see.
There must be 1 or 2 medical reasons to support.
Wow.
Because it's a procedure with potential complications.
Yes. It should be like a last resort.
So it shouldn't be an electively chosen something.
Oh, okay. I've been cleared on that now. So just an aside, I know the assisted pregnancy, the one we discussed about it some time ago, so conception, where most times they tend to have more than 1 baby.
Yes.
And usually it ends up being CS. Is it because of the fact that there are many and maybe pushing and all that? And I know now, even women with twins, they usually just go for CS.
Well, multiple reasons. Having more than 1 baby does not 100% mean you need a C-section.
Okay.
It depends on the woman's delivery experience. A woman who's delivered 1 or 2 babies before now carrying twins,
she should be able.
May not have to do a C-section, can push. But sometimes it depends on how the twins are presenting. Usually there's a leading one. The twin that is leading that determines everything else. The twin that's leading is in an awkward position.
It's the other one.
They have no other option than to, because the C-section will be a safer approach to delivery when you're looking at outcomes for the babies and mother as well, than using a vaginal route. So, but if you have scenarios where the baby's leading to coming with a head, or both are coming with a head, most likely with the woman who's delivered before, they're likely to achieve a vaginal delivery, barring any unseen complications.
So we want to just talk about.
But with the IVF too, usually the other factors are the fact there's been a long wait. There's been infertility that's been treated. There's been a lot of money spent on an IVF procedure, so the stakes are high. So it's difficult to tell somebody to go through that process, become successful, carry through 9 months, and they go through maybe the average labor is about maybe 8 to 12 hours, an 8 to 12 hour duration process to have an outcome that could potentially lead to complications.
So to just be on
sometimes
the safe side.
So the multiple babies and the history where they're coming from sometimes determines why they end up having a C-section.
Okay, I see. So before we talk about how CS is performed, let's say for instance, a lady has been informed that you would have to go through CS because of maybe your pelvic size and all that. What are some of the things she would need to do in preparation for this process? Like, what are some of the things a gynae would tell her to do to prepare for the session?
Well, first of all, I think you'll be, when you're antenatal or prenatal clinic attendance, usually at 37 weeks, there's a discussion on your birth plan. Are you going to do vaginal? Are you going to do abdominal via C-section? Once in the discussion, we'll take consideration what has happened before till now. Your previous history, whether you've had C-sections before, or maybe the baby is presenting an awkward position, or your placenta is actually in the way. So that will not allow for a smooth passage of the baby. So at 37, all the parameters or factors concerning this pregnancy will come up in a discussion in drawing up the birth plan. Once you are told to have a C-section, usually the first thing is you will know the reason why, which we call the indication. I'm having C-section because of X, Y, Z. Then once that, they will tell you the nature of the surgery, the purpose, deliver baby, deliver placenta, the duration, average duration, potential complications they would go through with you. And then if you do have a wish to sterilize yourself, maybe you've had 3, 4, 5 babies, you could also bring that up or be part of the discussion, and they can consent to a tubal ligation to tie your tubes. Because once we are in there delivery, we can have access to your tubes as well.
Wow.
So with all that, once the discussion is held, you sign a consent form agreeing to everything that's going on. So it's you, maybe your spouse, the doctor, or the medical member of the medical team on a consent form. And once that is done, you'll be booked for surgery. You probably have some previous labs done, blood tests here and there to show your state, whether you're fit. You may have anesthesiologist review you. Okay. They will give you anesthesia, decide whether it's regional or they'll put you to sleep or general. Then once that is done, a date is selected. Depending on where sometimes you are given the option to choose a date if they are being kind enough. Okay. So you can choose a date. Okay. So a date is selected, which is fair for all members. Okay. So usually you come in the evening before, and then once you come in the evening before, surgeries are done the next day. Okay. So evening before, usually morning of surgery, no food. If you're on certain medication, it may be omitted. Usually anti-diabetic medication, they are all eliminated, omitted for the morning. So you'll be, depending on what you're presenting with. So usually once it's done, they take me to theater, and then procedure is done. Within few minutes, maybe an hour, you're out of surgery into recovery. And then from recovery, maybe 2 hours in recovery, then from there into your ward, the lying ward. Yeah.
Okay, so we'll go on a quick break and we'll continue from there. This is still Ladyz Digest, and we're live with our gynecologist, Dr. Owusu-Ansah. We'll be right back. Welcome back, and remember you can drop your comments and your questions on our comment section at Ladyz Digest on Instagram and Facebook and YouTube at the Association of African Universities. We are still here with our gynecologist. Yeah, Doc. So before you ended, before the break, you spoke about the consent form. I just want an aside question. Are there cases, maybe emergency, where nobody is present and maybe the woman is, I don't know, maybe she can't even sign or something, where they do carry out the CS without the consent form being signed by
well,
the woman's side?
A consent form is signed almost every scenario, just that usually in an emergency situation, and depending on your presentation, whether you're conscious or semi-conscious, the medical staff can assume responsibility for you, and then sort of go ahead and state why, because of a state of presentation and everything. So emergency scenarios, the whole consent process probably will not be, it's needed, but it's not as rigorous as or methodological as the elective scenario. So yes, consent is always given, even in emergency situations. But yes, usually one of the staff could consent, or even any attending relative or whoever brought accompanying person can do. Usually would explain why we need to go in, and the person can consent on your behalf. If it's a scenario where you have pre-existing, what do you call it, someone with a power of attorney or something. You've done that already. Then that person can come up, and then you're not so responsive state signed for you or something.
So you spoke about the preparation and all that. I know definitely you may not be able to really walk us through the detail in the operation thing, but I know there is the cuts, the on the abdomen or something like that. And then I used to think that they cut it like the streets. I don't know if you can clear that. And what are some other things? What do you mean?
But there are cuts or incisions made on the skin.
Yes.
On the fascia or the tough tissue there.
Okay.
On the uterus itself. So which cuts were you referring to?
Okay, then when I was young, I used to think that they do the incision straight like this.
Up and down?
Yes.
No, it depends on what the scenario or the reason for going in. If it's very emergency situations,
okay,
usually we'll not use that fine lower abdominal cosmetic,
okay,
you know.
Oh, okay.
Because the fast entry is necessary.
Okay.
Okay. Maybe someone is bleeding,
okay,
or there's more is bleeding. The placenta has separated, but the baby is still alive. It's bleeding. It's usually needs speed to go in. So this is faster. The up and down is faster than the lower.
Okay.
Okay. You get the point. So yes, it depends. The scar you see may be dictated by the circumstances.
Okay. Okay.
Or something, you have a previous surgery that went that way. So usually whoever is doing a repeat surgery will have to follow that pattern. So it depends on. Yeah. But yes, if it's all planned and it's your first time and it's a non-emergency or elective, maybe yes, you could have the nice cosmetic.
Okay. So the one below is the cosmetic, the nice.
That is the aim.
Than
they call it bikini cut. So yes, it doesn't show on your.
Okay.
So it's like there are two. There's Vanessa and there's the Joan Cohen, which are all low abdominal cuts.
I see.
Yeah.
And I know they also speak of. I was discussing with my colleague and she was talking about. Is it the tummy tuck that at times when you do that you can tuck your tummy?
Yes, so that's an additional procedure with from the plastic surgical point.
Okay.
Where for multiple, maybe you've done 3, 4 babies, you're sure you're done with babies. Then there's some bit of sort of surgery on the abdomen. To try and restore the...
And that can be done during that process?
Yeah, it can be done simultaneously, so yes.
I see. That's nice. So let's talk about recovery after CS, and in the hospital and at home. About how many days, it may still depend on the circumstance, but about how many days would the mother need and the baby need to spend in the hospital, and what are the things they need to do, and also at home? Are there special checkups for them?
Typically, you'll be in hospital for 3 days, not counting day of surgery.
Okay.
So you get admitted the day before, the next morning surgery is done. Day of surgery is day 0. So the day after surgery is first day, second day. But the third day, most cases you go home.
Should be discharged.
Most nights. Occasionally, a few people stay beyond third day because of other reasons. Other complications due to baby, or maybe due to the mother, blood pressure has shot up, or there's some reason, or bled, or maybe had a fit, something. But if it's a straightforward, uncomplicated scenario, by the third day, you're home. In terms of being able to recover, usually because of pain relief, either intravenous or orals, they are pretty strong pain relief disease. So you're up and about very early. Because of good anesthesia as well, you're up and about early. So by the later part in the day, if it's done in the morning, you can set up, move around. Pain is bearable. By first day, you are up and about. By second, third day, you can do almost everything. But we usually don't allow heavy lifting or carrying stuff for that moment. When you go home, we'll give you a mandatory 6 weeks because it's a major surgery. Because it's also coincides with your delivery, it usually will come with, in most cases, your maternity leave, which is 3 months as well. So going home, you have, let's say, 3 months. Some cases, where they have C-section, it gives you 2 months extra, 2 weeks extra maternity leave to the original standard 3 months. So depending on where your jurisdiction is, you could get that. So, but in terms of recovery, right, first, second day, you're fine. If it's done well, good anesthesia, good surgical technique, good post-op pain management, you're fine.
Because I get scared when I hear, I think a colleague of mine then, she did hers, and for almost a week, she was having real abdominal pains. And I was like, is that how serious it is? And another thing is, I don't know, is it because of the fact that your skin has been cut? I hear because ladies like us would want to start putting on maybe immediately after birth, just like the vaginal delivery, you want to start putting on maybe your girdle or your corset to hold the stomach and bring it back to shape. And I'm told that with CS, you can't do that. As for like some, is it 3 months or
usually
so?
Usually the limitation is pain.
Okay.
Once the pain is controlled, you can put on your corset.
Oh, I see. So it's just the pain that's the...
Pain is the biggest challenge post-surgery. Okay. So if that's well taken care of, you practically won't feel anything, as if you've not been cut.
Okay. Okay, then that's fine.
So it should be fine.
Okay. So let's talk about where there are complications. I don't know if I can use the word CS gone wrong, but what are some of the symptoms of complications after CS that we need to, like a lady, when a lady starts seeing these things, she needs to call the attention of a specialist?
Okay, so it depends. I think I mentioned a bit of it earlier on. So once you have intra-operative complications, other bleeding, hard to control bleeding, damage to other structures, everything, obviously it will require more time as surgery. It will be anesthesia for long. There's some small increase of anesthesia complications because of the long exposure there. But what that means is that you may also need multidisciplinary, so other specialists may come in to maybe if your bowel has been perforated or your bladder has been cut because of maybe the nature of the anatomy or the surgical technique or the approach, something. So surgery may be long.
Okay.
That's just the first one. Then you go post-operative, let's say you're bleeding uncontrollably, you get dizzy, you get thirsty, going sort of into shock.
Yeah.
You become cold extremities, which may warrant going back to surgery to open you up again.
Okay.
To try and stop that. Or you may bleed postpartum from down there, where you have like what we call primary postpartum hemorrhage. Your bladder will not, your uterus will not contract. So you get bleeding, and then you may necessitate blood transfusion. So maybe we have to go back to go and remove the uterus if the bleeding is not stopping.
Wow.
So those are the other complications. Then maybe later on, maybe a few days later or weeks later, you may have wound infections with discharges, pain, difficult to heal wounds. You may have maybe bladder was inadvertently injured. You have leakage, or what we call like fistula, urine leakage, all those things. So those are the potential complications along the line.
Okay, so.
But then usually post-delivery, after discharge, after 3 days, you tend to do 2 to 3 reviews, depending on your antenatal history and the course of the delivery. So the basic standard is you are first seen 2 weeks post-surgery.
Okay.
And your second visit is 4 weeks from the 2-week visits.
Okay.
So like first visit is 2 weeks post-surgery.
Okay.
Second visit is a month later.
Okay.
But if there are other complications, you may first be seen 1 week after surgery, then 3 weeks, then 6 weeks.
6 weeks.
So it depends on what you came up with.
Okay. So pregnancy after surgery. I just want to get cleared on this one. If maybe a lady gives birth by CS for a first child or even second child, is there a possibility that she can give birth to the third child or the second child through the natural way, vaginal?
Yes. So we call that the trial of labor after cesarean, TOLAC.
Okay.
So if you had one C-section, usually there are a few conditions that must be sort of satisfied. Okay. And then that makes you eligible to try vaginally. Okay. If the scar is about minimum 18 to 24 months old. Okay. Healed well. There were no complications at the primary surgery in terms of wound healing and everything. You are carrying a baby who maybe at term, when term is when you're 37 completed weeks, was maybe 3.5 kilos or less. on ultrasound estimation or scan, you have a baby coming with the head down, okay? So, yes, you can have the trial of vaginal delivery after a C-section.
Okay.
We call that a trial of labor after CS, the TOLAC. So what happens is that there are few parameters or characteristics that or pre-requirements, I should put it that way. If you have the C-section done and the scar is about 18 to 24 months old,
okay,
the scar was made at term. Let's say you were almost 9 months plus when the scar was made or the cut was made for the previous delivery. You have a baby currently who is coming with the head is down, and it weighs maybe 3.5 kilos or less on scan. Okay. Good. Then most likely, and you have a previous successful vaginal delivery, maybe you had a C-section on your third baby. Okay. The other two were vaginal, successful. Okay. Those are favorable parameters that would qualify you for a trial of labor after the CS. So you could allow you to see if once labor comes, you could push vaginally. But if, let's say, the scar was made very early, preterm, usually it's not as strong as the term one, the scar. So if the baby is coming with a bottom, maybe it's very big, 3.5 kilos or 4 kilos, we don't want to stress such a scar. So those would disqualify you for a trial of labor, and that would mean a repeat C-section for you.
Okay. So we are on the last one. Just to enlighten her, or just give our guests some do's and don'ts after CS. As I know you mentioned not lifting heavy things, but other things, maybe your lifestyle, general lifestyle, and other things. Just the do's and don'ts.
Well, usually once you had a C-section and you leave hospital, they'll be giving a set of instructions.
Yes.
Usually what to eat, usually your regular diet. Medication will be given as well. Sometimes post-operative anti-clotting or anti-thrombin, anti-thrombosis prophylaxis medication will be given to prevent any clots
blood
forming.
clots.
So you get discharged home with these. In terms of lifestyle, no stressful physical activity. Give yourself rest. Well, it's not like to lie down and be. No. You want to. Just regular activity, no heavy lifting, nothing. Wound care, you'll be schooled on how to care for your wound. Sometimes they keep their dressings on. Some give you antibiotic sprays to use. What you don't encourage is going to put home traditional remedies on the wound to lead to infections, everything. So usually every aspect of the intended or expected post-operative care is touched on, and you are counseled as such. So if anything, you give you contact numbers to call to come in and everything. So once you listen to whatever is done for you, it should be fine. The other problems become culturally. Some people have ways they think a post-operative patient is taken care of at home. Don't do this. Don't carry stuff. You have to eat light soup only.
Light soup, hot one.
You have to. There are other little things that come in sort of. But generally, if you listen to whatever, because it's a procedure they did for you, whatever they tell you, you just listen, and you're likely to be fine.
Okay. Just a quick one. It popped up just now. I remember my colleague too. I think immediately after the surgery, they told her not to eat or so for, I think, a day or some hours or so. Why is that? And I think she was thinking of a baby because a baby too was in need of breast milk and all. Why is that?
Well, I think it's an age-old approach, post-op management, which it's changed, but in a lot of centers they still practice the. But in any case, determined by what happened at surgery.
Okay.
Usually, in the olden days, when we got exposed to surgery, most of the surgery were general surgery where maybe your bowel was handled and everything. When you handle bowel, it takes about 24, 48 hours for you to return to this activity. Okay. So generally, those days, when your bowel was handled, in general surgery, 24, 48 hours, no, nothing by mouth.
Okay.
Just to allow it to recover.
Yeah.
Okay.
Get back.
Over time, with C-section, for us in gynecology, we don't even touch your bowel.
Okay.
You go open the uterus, you're out.
Take the child in.
So for us, by 12 hours, you should start eating. In modern day approach, unless there were complications where your bowel was attached and all that. So usually it's determined by what happens inside surgery, and the surgeon will actually indicate.
Okay.
Like keep nothing by mouth for 12 hours, 24 hours, or even 48 hours, depending on what went on. It's part of the post-operative instructions to the nurses and other staff. But if it's a straightforward, uncomplicated thing, you can even eat by 6 hours.
Wow, okay. That's fine.
Yes, starting with something light, of course, not something
heavy. Light,
Sometimes, I think it's also born by experience where some surgeons have had, let's say, I know I was going to have surgery, so maybe for morning I was starved. So in our super society, you prepare something heavy waiting. And the moment you give them a go ahead, they go and then trouble comes. So that is also been, so sometimes it depends on the experience.
Okay. Thank you very much. This has really been an enlightening session, and we appreciate you for coming. This has been Ladyz Digest, and I just want to say a quick one. This show doesn't serve as a substitute for you visiting your healthcare. You should always go to your doctor, and you can always visit the your health center for more on it. This is just a little insight, and this has been Ladyz Digest. I have been your host, Joan. Until I come your way next time. Many thanks to my production team for making this production a success. Bye.